morning, everybody. My name is Benjamin Diven. I'm LCFD's medical director and have been now for going on 11 years. So you are all accustomed to abuse by me in image trend and in messaging and constantly changing your protocols to keep you on your toes. Today we're going to talk about 4 drugs that have been opened up by the State EMS Medical Direction Committee that I've been on since its inception in the 90s. These open up new drugs to basics, intermediates, and paramedics, and we're going to go over them. Hopefully you have my training sheets with you. If not, they'll eventually make their way to you to help summarize the drugs in a cogent way. The first drug is ondansetron, which is better known as Zofran because I can't pronounce ondansetron consistently correctly. Zofran has been approved as an oral dissolving tablet for EMT basics now. This is a nice step forward because we give a lot of Zofran. It has very broad indications, and there's a lot of hands on deck with these calls, and being able to delegate to another EMT a job is always helpful. Zofran works as a serotonin agent in the GI tract. Serotonin is all over the place in the body and is a very active neurotransmitter. So Zofran has a very specific receptor. It does not go elsewhere very much and has only one contraindication, so it's an easy, safe drug to use. It's indicated for nausea of any source. This could be somebody having an MI who's nauseated. This could be somebody nauseated because they're lying backwards in a moving ambulance. This could be from infectious disease. It doesn't matter what the cause of nausea is. Zofran can be used and it is effective. The oral dissolving tablet comes as a 4 milligram pill that the patient just has to place under their tongue. It dissolves very rapidly into saliva, is easily swallowed, and does not stimulate nausea. The dose is simple. It's 1 or 2 tablets at a time. As a general rule, it doesn't need to be repeated. It has a long enough bioavailability that you shouldn't have to give more during your patient contact time. The oral form, as an oral dissolving tablet, has the same bioavailability as the IM form. So you're really working with a very effective, simple intervention that is going to do your patients some real good. The drug interactions, there's one funny drug, apomorphine, which you don't even hear of apomorphine anymore. It has an interaction with that, but you're never going to run into that. The contraindication is prolonged QT interval. Zofran is used millions of times a day in the United States. Nobody asks about prolonged QT interval. And we know that patients are receiving it who have prolonged QT interval and do not have adverse reactions. Nevertheless, I need to warn you about that. If you think about it and remember, ask. Patients generally don't know they have prolonged QT interval on their EKG. The few that do will tell you, or they'll try to remember what it is, but they won't remember specifically. So it's a relative contraindication. If you know about it, use promethazine and have an intermediate take over the nausea treatment. The age range goes down to 12, and you can use 4 milligrams between 12 and 17, and then 4 to 8 milligrams after 17. So it's fairly easy to remember. And it's illustrated in the nausea and vomiting protocol, which I've copied out. That's a very straightforward protocol. As the protocol is currently written, it just shows Zofran as an AEMT indication. But now you know you can give it as a basic, and eventually I'll get in there and get that changed so that it says basic through paramedic for Zofran. Okay. Hopefully you don't have any questions about that. The next 2 drugs have been opened up for intermediates. These are really a big step going forward for intermediates, I think. They're both powerful drugs. They both have very clear indications. They're both very, very safe. And they're both very, very effective. The first one we'll talk about is Pitocin or oxytocin. Oxytocin is a naturally occurring hormone secreted by the pituitary, if I recall correctly. It has 2 properties. It is vasoconstrictive and stimulates uterine muscle contractions. So, oxytocin is used to prevent and treat postpartum hemorrhage, and that is its primary indication. There are no contraindications for it. As I said, it's naturally occurring, and comes in a vial that is measured in units as opposed to milligrams. And I believe the vial is 20 units, it may be 10 units. I'm not certain about which it is. Look at it closely because you'll need to know that to draw it up. The first indication is in any field delivery, the mom should receive 10 units IM, regardless of whether there's bleeding or the placenta has delivered. Those are both irrelevant. They should all receive 10 units intramuscularly as a prophylaxis for postpartum bleeding. The literature is very good on this and very clear that this can help prevent postpartum bleeding, which happens to be the leading cause of death in maternal childbirth. The second way it's used in postpartum hemorrhage is as an IV infusion. This again has very simple med math. You take 20 units of oxytocin, insert it into a 1 liter bag of any fluid of your choice, probably normal saline or lactated ringers, and you use a 10-drop IV set. You set it up IV or IO, and you run it wide open. Normally, this should be done after TXA has been attempted, but it doesn't have to be after TXA is attempted. If you have active postpartum hemorrhage that is worrying you, this is the second step. IM oxytocin followed by IV-IO oxytocin. And don't worry about the placenta. That's something that will come out. The oxytocin may stimulate placental delivery, in fact. There's one drawback to it, and the moms will tell you this, that contraction of the uterus by oxytocin can be pretty uncomfortable. They may complain of cramping. That's a normal side effect of it and an indication that it is doing its duty. There's no treatment for that. It's just a discomfort that the patient has to cope with, unfortunately. Now, we're going to talk some more about bleeding. Oxytocin, as I said, is safe, effective, easy to administer, and you shouldn't be afraid to use it. I've had a recent case, we may use it as a scenario for your training of massive postpartum hemorrhage where oxytocin was clearly indicated. The second drug that's now available to intermediates, and again is a very positive step forward, is tranexamic acid, or TXA. TXA is a very interesting drug. It dates back to the 1960s and was developed for bleeding and surgery. The earliest patients it was used on were pediatric patients undergoing tonsillectomies. It was also used early on for postpartum hemorrhage, but mostly it was used in the operating theater. It's interesting because although it was used, and most of the literature is European, there's not as much American literature. It wasn't until the Iraq and Afghanistan conflicts that TXA came back into popular demand. The military discovered it, began to use it, and used it with good results in hemorrhaging soldiers from battle wounds. Their literature is very robust and defines TXA as a potential lifesaver. It reduces the amount of blood needed for transfusion and is very effective. You won't see that effect in the field. It takes longer to work than you're going to notice. TXA works on plasminogen primarily in the coagulation pathway. What its main outcome is to preserve clotting. Clotting is a funny thing in the body. As we clot, the body is constantly replenishing the materials of the clot, but it is also breaking the clot down so fresh material can be inserted in. TXA stops that breaking down. It doesn't stimulate clots, it prevents them being broken down. The net effect is to stimulate clots by that backwards mechanism. Its indication, and this is really important that you get this down, is clinically significant, non-compressible hemorrhage. The non-compressible part is a no-brainer. If a tourniquet, pressure, clotting gauze, or perhaps the new drug we're looking at, trauma gel, are not effective at stopping the hemorrhage, it is non-compressible. But the kicker is clinically significant hemorrhage. TXA clearly works better the worse off your patient is. It's very effective in hemorrhagic shock, but I feel strongly that it should be used before the patient is in shock. I think by that time you're chasing your tail. So by clinically significant, I mean the patient is showing some sign of hypovolemia from hemorrhage. This could be anything: diaphoresis, altered mental status, pallor or grayness, tachycardia, bad sign is bradycardia, hypotension, tachypnea, any of these findings that make you think the patient is clinically significantly bleeding are adequate indications in non-compressible hemorrhage to give TXA. This is always the sticking point, getting the clinical indications straight. I don't think you should wait for hemorrhagic shock. I'm very liberal with TXA, but I do want you to be looking for any sign that the patient is suffering from the hypovolemia due to bleeding. This gets tricky with internal bleeding where you just don't know for sure if bleeding is occurring. I just reviewed a stab wound to the flank, right where the kidney and liver reside. On the other side is the kidney and the spleen. Very vascular organs. And the patient was mildly hypotensive, not too tachycardic yet. TXA was given and absolutely indicated, I think. There's some new literature on femur fractures and pelvic fractures. It turns out patients do not bleed as much as we used to think they did with femur and pelvic fractures. So once again with those, be looking for those clinical signs: diaphoresis, pallor, altered mental status, tachypnea, bradycardia, hypotension, tachycardia, any of those things to give you the indications for TXA. There's two ways to give it. The first is always within 3 hours of the onset of bleeding. For reasons that nobody understands, TXA aggravates hemorrhage after 3 hours. The sooner you give it, the better. There is kind of a curve from 1 hour to 3 hours where it becomes less effective. It's not a dramatic slope, but there is a little slope from 1 to 3 hours. So the sooner you can give it, the better. It's contraindicated, of course, if there's an allergy. Allergies are exceedingly rare. I've never heard of one. The patient's never going to have heard of it. The GI bleeding is under study. Upper GI bleeding probably does not respond to TXA. Lower GI bleeding may respond to TXA. This is all being studied right now, but it's of interest that GI bleeding is not an indication. Intracranial bleeding is also under study. There's no question open bleeding of the skull with fracture or just scalp involvement is an indication, even when TBI or traumatic brain injury is present. But strictly intracranial bleeding, such as a ruptured aneurysm, which you might well suspect clinically, is still under study and nobody knows if TXA is helpful there. Now, to administer it, there's two ways to do this. This is a bit of a debate still in terms of how to administer it in trauma and hemorrhage. But the way I read the literature, the best way to do it and the simplest way to do it is to give 2 grams mixed in 250 cc's, running in over 10 minutes. If you don't have 250 cc's, if you only have a 100 milliliter bag, you can do it that way too. But run it in over 10 minutes. There is some vasoactive property to TXA. The patients may feel it if you give it faster than 10 minutes. Now, of interest, this is a brand new paper that came out from the American College of Obstetricians and Gynecologists on TXA and postpartum hemorrhage. They propose a different dosing regimen. They state that it is literature-based and science-based, but I have never seen that literature, so I'm taking it on their word. In postpartum hemorrhage, it is 1 gram mixed with fluid administered over 10 minutes. If the hemorrhage continues at 15 minutes, you repeat the 1 gram dose over 10 minutes. That's quite different than doing it 2 grams all at once. I don't know really the reasoning, but they were very clear on this in their most recent position paper on TXA and postpartum hemorrhage. We recommend, and this comes from most of the trauma centers, using it in 16-year-olds and older. But, as I mentioned to you, when it was first discovered, it was used in children. And there really is a very big surgical literature showing it to be safe in children. So, what the Medical Direction Committee has asked is that if you wish to give it to somebody younger than 16 years of age, you seek online medical direction. Hopefully, you get somebody who is familiar with the drug and familiar with the literature and will give you the go-ahead because the data is there. But as it stands, medical direction wants to keep it at 16 until the literature, the current literature, becomes more robust. We're looking at papers from the 60s right now, and they want something more modern. So oxytocin and tranexamic acid, or TXA, are new to you as intermediates. They're both safe, effective drugs. You should not hesitate to use them. As I said, the indications are straightforward. The contraindications are very few, and I think you'll find them very useful. We do not see a lot of postpartum hemorrhage, but we do get some whoppers when we do. But traumatic hemorrhage and other forms of hemorrhage that lead to hypovolemia are very common. So you'll be using a lot of TXA. Okay, the last drug is by far the most complex, and we're going to talk a little bit about this. This is olanzapine. The brand name is Zyprexa, but I usually refer to it as olanzapine. Olanzapine is a second generation, meaning new generation, antipsychotic drug. The Medical Direction Committee approved 3 antipsychotic drugs for use in the field in New Mexico in the new scope of practice: Haldol, droperidol, and olanzapine. For those of you who are familiar with antipsychotic drugs, Haldol and droperidol have many, many side effects and are extremely sedating and need very careful EKG monitoring. The manufacturer actually recommends a 12-lead EKG before giving droperidol. This is because of EKG abnormality and arrhythmias from these drugs. They also produce dysthymic reactions and are really a pain to administer and to monitor. The ERs do not enjoy those 2 drugs because of the prolonged monitoring time that is necessary. Olanzapine, on the other hand, has much fewer side effects and adverse events associated with it. It works by stimulating dopamine and, again, serotonin receptors in the central nervous system. It came out originally as a drug for schizophrenia and was wildly popular and successful. Its drawback as a long-term treatment is that it produces an increased appetite and people gain weight. That has been its primary limiting factor in its popularity. Now, the indications for this are several, but the two main ones we want to talk about is psychosis and undifferentiated agitation. Psychosis occurs with a major mental illness as a general rule. Most of the patients you're going to see will know they have this illness, but you get into teenagers and young adults, and then it gets a little tricky. These people can have their first onset of psychosis or a psychotic reaction to some event in their life and not have a diagnosis consistent with a psychotic disease. Those will be trickier patients. Psychosis hallmark is hallucinations, detachment from reality, and delusions. Hallucinations are generally auditory and not visual. Visual hallucinations are usually associated with drug use or dementia, and in older patients who have a metabolic cause for their psychosis. So you're looking for agitation, hallucinations, delusions, basic detachment from reality. This is going to be in patients with schizophrenia, bipolar disorder, mostly mania, major depressive disorder with a psychotic feature, schizoaffective personality disorder, which again is a form of schizophrenia, though milder and in a personality disorder phase. Some people, as I said, can become psychotic for reasons that we don't understand. Olanzapine is very effective acutely in psychosis, and I think you'll find that it fills a niche in our sedation protocol. As it stands now, we sedate severely agitated patients who are a danger to themselves or others, whose agitation prevents thorough assessment when there is danger to the patient without a good assessment and therapeutic interventions, and agitation from drugs, illicit drugs, prescription drugs, alcohol withdrawal, drug withdrawal. There are lots of causes of undifferentiated agitation. With olanzapine, you probably should stick to undifferentiated agitation that is not associated with other drugs. It is adding one drug to the mix and can be harmful with drug interactions. So think of it as a drug primarily for psychosis and clean, undifferentiated agitation. Now, before you even think about giving olanzapine, I want you to take out my very long, very wordy sedation of the agitated patient with medication protocol. I wrote it when we first started sedating patients, and after I was convinced, reading the medical literature, that sedation was a good idea. The indication for sedation is primarily the well-being of the patient and the safety of you as caregivers. You don't want agitated, combative patients in the back of an ambulance. You don't want patients in handcuffs prone in the back of an ambulance. You don't want patients in the wrap if you can at all avoid it. All of those interventions put patients at risk for hypoxia, for circulatory collapse, and trouble. Medications used to sedate these types of combative, agitated patients are much more humane and much safer. But it is still a big deal to sedate a patient. Think about it. You are not getting informed consent. You are not honoring their civil rights. You are literally going to sedate a patient so they are at your mercy to care for them. So you have to act in good faith. Good faith means merely acting in the patient's well-being interest. So I want you to read my long, wordy, agitated patient protocol and review ketamine, midazolam, and olanzapine, and try to get a feel for each one of those has its own kind of niche. I review every case of sedation LCFD performs, whether it be midazolam, ketamine, and I'll be reviewing olanzapine as well. I believe it is a high-risk, low-frequency procedure, and I have found that within the department, you guys and gals consistently exercise good judgment. You choose your drugs well. You use good judgment for patients that need to be sedated, those who just need to be calmed down, and you manage the side effects expertly. So I don't worry a lot about sedation. We only do it about once a month, maybe twice. Midazolam is used more frequently, but less as a sedating agent and more as a calming agent. And it works very well for that. The contraindications are, of course, allergy to the medication. This is very rare. You're not going to run into very many people who say they're allergic to Zyprexa or olanzapine. The one group you don't want to use it in is psychosis associated with dementia in an older adult. This has been associated with bad outcomes, mostly in people who take it chronically, not so much in people who are getting a single dose of it. But nevertheless, it's a group you want to avoid, dementia-related psychosis. The adverse events, there can be several, and they're fairly uncommon, and nothing that you can't manage in the field. Tachycardia, hypotension, bradycardia, it can be sedating, respiratory depression, some anticholinergic symptoms, and really rarely extrapyramidal symptoms or dysthymic reactions. These are all rare. You can easily manage them in the field, but I don't think you're going to find yourself up to your ears in adverse events with olanzapine. It is not a weird drug like ketamine, which can have some surprising effects. Now, one of the tricky parts is mixing this stuff up. It comes as a 10 milligram vial as a powder. You have to mix it up with 2 milliliters or cc's of sterile water. The manufacturer specifies sterile water, not saline or lactated ringers. I don't understand the necessity, but that is the indication. The problem with sterile water is that it stings when it's injected, but you're only injecting 1 to 2 cc's or milliliters of olanzapine. So you're probably not going to be causing the patient much discomfort. This 10 milligrams of olanzapine powder, you mix it with 2 cc's or milliliters of sterile water, and then twirl the bottle in your hands. This warms it and also mixes it. Do not shake it because you're going to get a lot of bubbles and have trouble drawing it up accurately. Spin it in your hands till it is a clear yellow liquid. You now have 10 milligrams of olanzapine as a liquid. The dose is very straightforward in adults. It's 18 years and older, and it is 5 to 10 milligrams IM, not IV, not IO, IM. You can start with 5 if you think that that would be effective and add a second dose of 5, but up to 10 milligrams as a single dose. This can be repeated in about 20 minutes or so. You need 5 to 10 minutes to begin to see if it's going to be effective. Within 20 minutes, you should know if it's going to be effective or not. If you're dealing with a patient with a proper indication, then feel free to repeat the dose at 20 minutes. Of course, the more you give, the more likely you are to have side effects. So be careful in your monitoring of these patients. Sedated patients should all have oxygen, pulse oxes, end-tidal CO2, and cardiac monitoring. That's just good medical practice with any sedated patient. There's a special note in your handout to be cautious with patients where you do have to use it and you think another drug or alcohol may be involved, but the drug is still indicated because of psychosis. You may be tipping the balance toward hypotension. No big deal. You're going to have an IV by this time, hopefully, once they've calmed down, and you can bolus them with fluids. It is very, 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 very rare that you would need a vasopressor for the hypotension you might experience with olanzapine. But once again, I encourage you, please reread the sedation protocol because there's a lot of information in there. You always know I'm nervous about something when I write a long protocol. Sedation is always for the well-being of the patient, for your safety, and for the assessment and treatment of patients who are seriously ill or injured and need to be sedated for their care to continue. That is a fairly broad indication. If you read the scope of practice, it says severe agitation, and I'm a little bit broader than severe agitation. We're going to look at that language this year with the scope of practice when we revise it again to try to broaden the language a little bit because it's not exactly consistent with olanzapine's indications. And that's it for today's review of 4 good new drugs, and I wish you good hunting out there.